Welcome to the Pilates Hour today. Looking forward to talking to you about multiple sclerosis today. So we're going to do a brief summary of the disease itself and how it affects us. And then we're going to move right into an interactive case study. As you know, we love bringing you free education and being able to introduce you to information that can be useful in your Pilates studios, your clinics, and even for yourself. In this particular one, I invited a number of people that I knew were actually suffering with multiple sclerosis to join us today. And again, the more educated we are, in Polestar we say we like to educate and practice, the better we're able to help people in their journey to move. And movement, we believe, is at the essence of the quality of each of our lives. And so we're excited to do that today. Looking at the brain just in general, because what multiple sclerosis is to a lot of people is very confusing because we don't quite understand how does it affect so many different parts of the body and so many different systems, and how come it lasts a long time in some individuals and very short, brief segments with other individuals. And what I wanted to show first is just the brain is incredibly complex, but there are sections of the brain that start to make sense that multiple sclerosis is an autoimmune disease. It's where the body identifies the myelin that surrounds these nerves, and it causes them to not work. And it actually causes an inflammation, and that inflammation results in scar tissue, and that is a plaque or a sclerosis. That's where the name comes from. So when somebody has multiple plaques or multiple scleroses in their brain, they are diagnosed with multiple sclerosis. That's sort of the general term of where the name came from. So if you look here, like Wernicke's area is for speech, and there's different areas for interpretation of speech. There's the motor cortex and the sensory cortex. There's the visual cortex. Any of these parts of the brain can be affected by multiple sclerosis. So what that means is somebody might have weakness in their legs, others might have sensory problems, others might have visual problems or speech problems that are associated with the same exact disease, even though the symptoms could be remarkably different. In this next slide, you can see it's basically a MRI that is looking at a cross section of the brain and being able to identify those white little dots. And those white things are the scleroses that we're talking about. They are the scar tissue around the nervous tissue that is causing the problems, right? So the key concept and terminology we use, multiple sclerosis, we look at the incidence happens in a younger generation, predominantly female. So we often see young women, teenage years, adolescent years, young adult years getting their initial diagnoses of this disease. And I was just reading something in my pathology book that as we get more and more information and more about genetics, we're starting to learn that there are certain inhibition genes that seem to be missing in certain individuals that are more susceptible. We don't really understand the cause. We just understand the disease and what's going on, but we don't really understand why autoimmune disease attacks different parts of our body. And when we talk about autoimmune disease, there are many. For example, rheumatoid arthritis is an autoimmune disease, and it in particular attacks the joints, but it also can attack the heart valves. It can cause an inflammation systemically of the body. It can cause erosion of the joints, and that's what we talk about rheumatoid arthritis. Lupus is an example of one. There's scleroderma is one of the connective tissue. All of these are autoimmune diseases where the body is overactive in its immune system, and it identifies things in our body that are normal human tissue as antigens. And in that cause, it's going to cause inflammation, and inflammation often causes damage, scarring, or deformation. And that's what we're looking at here, as multiple sclerosis is an autoimmune disease of the central nervous system. So again, here we can see a number of plaques that are present in this brain scan, and this is sort of how the physician would make the diagnosis, among other things. But typically you're going to have multiple symptoms that would be manifesting that are more systemic, don't necessarily make sense to the individual. They go to a neurologist. The neurologist takes an MRI, or a CAT scan, and they're able to see some of these plaques. And based on that and some other tests, they make the diagnosis of multiple sclerosis. Now, in and of itself, multiple sclerosis has many different levels or degrees of severity. So there are some who have reoccurring non-residual multiple sclerosis, meaning that it could happen often, but it doesn't have any permanent lasting disabilities. And that can go all the way up to those who maybe have one major episode of it that leaves them with permanent disabilities. So it's very, very wide spectrum of what we might expect in this population. So this is what I was talking about with the myelin sheath that surrounds the nerve. And the myelin sheath is known for being able to do a saltatory conduction. Saltatory conduction, saltatory is the word jumping, means that the nerve impulse can jump faster and travel faster through a nerve when it has this myelin sheath and being able to do the saltatory conduction. So when these fibers are damaged from the inflammation, the nerve loses its effectiveness and often leads to some kind of impairment. So again, if this happens in the motor cortex, depending what part of the motor cortex it is, it could cause weakness in certain parts of the body. So if it was in the motor cortex over the lower extremities, you would see weakness in the lower extremities. If it was over the upper extremities, you would see weakness in the upper extremities. It could also affect things like speech. It could affect things like chewing and swallowing, and even could affect some of the things that have to do with normal autonomic functions in our body. Here we're looking at the actual sort of definition of multiple sclerosis. It is an autoimmune condition in which the immune system attacks the central nervous system, leading to demyelination, which we've talked about already. The disease onset usually occurs in young adults, and it is more common in females. It has a prevalence in the range, which is pretty high, 2 to 150 per 100,000. So it also depends on the regions in the world. So colder areas tend to have a higher incidence of multiple sclerosis than hotter areas. And again, not quite understanding if that is more of a genetic relationship to migration of where people live, or if it really is related to some kind of environmental condition. Is it related to some kind of environmental exposure to a toxin? A lot of these autoimmune diseases, for example, rheumatoid arthritis, we do know a little bit more about, is that smoking is a huge factor that leads to setting off the gene that would cause rheumatoid arthritis. So what you'll typically find, somebody who smoked for a number of years, then has sort of a stressful incident in their life, and they trigger the genetic code that they have already, and then they have the autoimmune disease that attacks their joints. So it's a very interesting process in understanding autoimmune diseases. So the etiology of multiple sclerosis, that's sort of the science of where it comes from, says the body's own immune system attacks and damages the myelin. When myelin is lost, the axons can no longer effectively conduct signals. So it's a very mechanically based disease. When it destroys the nerve, right, it destroys the axon to the nerve by destroying the myelin, then it no longer conducts the signals that need to be there for our function. And although much is known about the mechanics of multiple sclerosis, we still do not really understand the cause. As I mentioned, theories include genetics, infections, different environmental factors that have been found to be associated, no direct causes that we know of. And I do think that the research in MS is really making headway in looking at the genetic predispositions, and I think this is true with all autoimmune diseases, that when we really understand what are the factors that trigger the genetic predisposition. So we have two ways of looking at it. One, if we can identify the genome and be able to say, oh yes, this family is carrying this gene that it does inhibit or doesn't inhibit this particular genetic activity, what are the triggers then that cause that to happen? So are the triggers stress? Is it some kind of environmental exposure, some kind of toxicity? Is it a metal? We don't know. But as we get that information, then we can have two ways of looking at it. One is genetic counseling, and two is looking at prevention by managing the potential risk factors if you do happen to have that genetic risk. So I want to present to you a case study. A particular case study is really sensitive to me. Jenny was actually a babysitter of mine when I was a young kid. And when I came back from college years later, I found out that she had been diagnosed at 19. She was now 39 when she became a patient of mine, and 19 years old with multiple sclerosis, which sort of fits the criteria of a young teen or young adolescent. She was having a lot of strength issues in her legs. She was having numbness and weakness. Wasn't sure what was going on. By the time she went to the doctor, ran through tests, 19, she was diagnosed with multiple sclerosis. And she happened to have a very aggressive version of multiple sclerosis with frequent episodes with severe residual limitations. And this would be the worst case scenario of multiple sclerosis, where every incident she had would take away a little more function in her daily activities. She currently is disabled in the state when I saw her a number of years ago, and she relies on a front wheel walker for her locomotion and is considering going to a wheelchair. So a couple insights. In the interview, I always have done this for years and years and years. I ask, what do you believe you should be able to do that you're not able to do right now? Now, Jenny and her husband had just adopted three orphans, three brothers, ranging from the age of 3 to 8, that she became an instant parent at this stage with multiple sclerosis. And what she realized is, as much as she wanted to have children and wanted to be able to raise a family, was that her ability to raise these boys was limited based on her energy, based on the fatigue that she felt, and her ability to move. So when I asked her, what do you believe prevents you from participating in these activities? She just said, I have whole body and mind fatigue, and I'm feeling depressed. We're going to have a couple questions throughout the case study that we'll have you participating with. Again, I believe in this type of learning. We call it formative learning, where you get to be able to participate. There's no grading. Nobody can see what you entered, but the process of you thinking through these things increases your ability to retain information. It increases your ability to be able to apply it and integrate it into your practice. So before we move into the assessment with Jenny, what I'd like you to do is think of just the basic subjective information that we got from Jenny in the two questions and in the history. What would you hypothesize Jenny needs the most right now? And again, this is wide open. Whatever you think, this is sort of open for your thoughts. Now, while you're doing that, I want to bring to your attention again the two things that she suffered most from. And the first one was fatigue, and the second one was depression. So fatigue, weakness, and depression. So thinking of those three things, what would you want to do with Jenny? How do you think that we as Pilates teachers and physical therapists could help her, especially as being an instant parent of three young boys? Let's go ahead and show the answers. Yeah, good. I see some good answers in there. You're thinking outside the box. And that is that maybe some of the most important things we could do is to create some positive movement experience for her. Thank you very much, whoever wrote that. Relaxation techniques, encouragement, being able to help her with mental support. The depression is outside of our scale. So a psychologist or a psychiatrist referral, a counselor, somebody that could help her with that. Introducing gentle movement, right? So for her, she's not exercising at all. She feels so fatigued and weak and depressed, it's hard to be motivated even to do anything. These are some great answers. Thank you very much. Let's move on to the next segment here. While we're doing that, Sarah Edwards, how are you doing in England? Said, hi, Brent, interesting case. Was she referred to you? I'm just interested in her motivation to improve given her depression symptoms. She came to me on her own. So I think that she hit the wall in her current situation, and she just decided to come to me. She knew I was a therapist. She was proud of me as one of her kids she babysat in high school. And I think she just wanted to have a better quality of life. And I knew her through a church relationship before she became my patient. So in the medical test, we found the MRI, she had positive plaques throughout the central nervous system, and quite a few. She had paresthesias in her extremities, so a lot of sensory loss, weakness. You think of like neuropathies. Some of them were painful. Some of them were just numb. Some of them were pins and needles, and very diverse. And it would change sometimes day to day. She also had partial paralysis, so a lot of weakness in different areas. Like, for example, her gastrocs were very weak. Her quads were very weak. But she would have tremendous spasms in her calves or in her hamstrings, particularly from sitting. So when I did her initial assessment, posture, she was not able to stand without the assistive device for any length of time. Posturally, she was slumped over, forward head, rounded back, weakness in the arms, even in the triceps were tough. Sometimes she'd have to have that forearm control for her on the walker that she could lean into a little bit and rely on her shoulders, which were also weak. From an active range of motion standpoint, she had decreased range of motion pretty much in the entire body. So you got to think inactive with the disease process. Some restrictions were due to joint restrictions, and some were due to neurological spasticity. So as I would take her leg through a range of motion, sometimes I would find spasticity or clonus. Other times I would find flaccidity, but restriction in the joint or in the tissue, and a very mixed representation, which is not uncommon with this disease. We looked at her strength. Basically, her lower extremities were a 3+ to a 4-. What that means is that she had strength that she could, put herself up into standing, but she couldn't do it for longer than like 5-10 seconds at the most. So we would typically say if she couldn't stand at all, she would be a 3, right? So 3 is you can't tolerate gravity. The strength of the upper extremity was a 3 out of 5. So just trying to lift her arms up against gravity was almost impossible. She also had poor sitting tolerance. So she'd sit in her chair, and pretty soon she'd be collapsed over to the side of the chair. It's very hard for her to sustain a neutral posture and sitting for any length of time. The question comes, and again, think of this as a chronic disease. This is somebody who very likely could show up in your Pilates clinic. What functional test would you want to use or to do or perform as a way of measuring Jenny's progress, what her starting point is and where she's going? And again, it doesn't have to belong to any particular type of functional test. What do you want to know that she can do or can't do, and how would you measure it to see what that looks like? Just to give you a hint, if we go back and think of what she could and couldn't do, right? She had a hard time transferring, getting up out of a chair. She had a hard time standing for longer than 5-10 seconds. She couldn't lift her arms up against gravity. She had a hard time controlling some of the spasticity. She had decreased range of motion. Some of it was due to joint restriction. Some of it was due to neurological spasticity. So this sort of gives us an idea of thinking like, what would you prioritize as a functional test for Jenny? Something that she would go, if I could do this, I would feel better about myself. If I could do this, I would have this much more function. Sit to stand is the number one that I did, and standing balance, very good. Goal post and reach, and again, goal post, she has a hard time lifting her shoulders up. So it's a great test for us to show she can't do it now, and it would be great for us to see if she could do it later. That's the whole idea, right? And being able to find something that she's going to be able to do sooner than later. I like the hand grip and the push up and pull, the push and pull. Good. Ability to sit and stand, lift extremities, deep breathing. Breathing is very labored for her. That's why I think she was always fatigued. So I'm glad somebody brought up breathing. That's going to allow us to get a little more endurance. And remember that in the world of MS in particular, our biggest concern is not to overheat our clients, right? So we talk about this a lot with neurological impairments, neurological disease, is to avoid overheating our clients. What that means is that we don't want them to go to exhaustion because the aftermath of that could wipe them out for 3 or 4 days or could exacerbate their symptoms. So we're always very careful we want to push them. We always want to challenge the tissue. We want to challenge the lungs, but we push them to a level that does not overheat them or cause an adverse effect. Now, what inevitably happens is somewhere in our journey working with these clients, you are going to overheat them if you're trying to push them to get better. And it's not the end of the world. It just means they're probably going to have a bad week. And so we want to be careful of that. But when we start understanding the limits, it makes it a little bit easier for us to know what's just before that limit so we can take them to that point and be able to give them a good movement experience without them having negative byproducts. Again, I'm watching some great answers coming in. And again, if we go to the next slide, you'll see that I also felt that sit to stand was the main one. And she was able to do sit to stand with min assist. What that means is that I could give her balance awareness. That was really more of the challenge, and endurance assistance. So by me being able to, to be able to help her do that, and then obviously when I tried to do just even a marriage proposal with sticks, she was not able to bend down at all. So basically she was very scared of having that, even holding her for balance. So then we did a balance test standing with both feet together and no assistance, and she was able to do that for about 5 seconds on both feet. So it wasn't a single leg balance test like we do with a lot of people. That she wouldn't have been able to do. But 2 legs, it was about 5 seconds. So we typically want people to be able to do a single leg balance for about 10 seconds would be a more normal outcome. Sitting, side bending, and rotation, she was about 50%. Really had no sense of lumbar stability. So it was more of a collapse side to side, and there was a loss of thoracic mobility. So be thinking of how can we increase a little more trunk control and increase a little more thoracic mobility that might result in greater shoulder mobility and be able to restore a little bit of upper extremity strength and mobility as well. She was not able to tolerate the prone position, right? And this was due to tight hips. This is not uncommon with people who spend most of their day sitting or that have neurological impairments, strokes, severe spine injuries, often will have very tight hip flexors. And when they try to stand up with poor core control, what ends up happening is a shear force that often causes a lot of low back pain or does not allow them to get over the center of gravity. These are some of the challenges we have. This was also the reason why she could not stand up all the way straight, is because her hip flexors were too tight. And when we tested her laying on her stomach, she was not able to straighten her legs out. So immediately thinking this is more of a structural restriction in her hips than it was a neurological restriction, and probably due to behavior. So if we could change that behavior, if we could mobilize that tissue in those hips and get her to have straight hips, it would be a lot less energy to stand up and a lot less energy to maintain balance. What do you believe could help Jenny be able to walk without so much pain, without so much weakness? What could we do with Jenny? She has a walker. What do you think would be the most important thing for us to do? While you're thinking about that, I want you to think again, hip flexor restrictions or hip joint restrictions. When we cannot get up on top of the legs, we are not able to use our hip extensors. We're not able to use our trunk muscles. So even if you were to test it and just be pitched forward and standing up, you'd realize that pretty soon your back is going to be hurting. Pretty soon you're not going to be able to, you couldn't balance in that position. There's too much weight going forward. So again, thinking of how could we help Jenny walk? And I made a mistake by putting pain there. With her, it's not so much pain. I would change the word pain with fatigue. Yeah. All right, let's see what people are saying, Melissa. So mindset improvement, passive psoas release, some footwork, gentle glute work, leg strengthening, open hip flexors, good. Alternate knee lifts and chairs, you're thinking on the right line there. If anything, any way that we could get knee extension and hip extension for her to be able to stand up straight would require less neuromuscular contractions to be able to maintain that posture. lay on two semi-soft balls under the sacrum. Very good. Lots of sort of myofascial release, whether it was manual therapy or whether you're using myofascial release tools. Back in those days, we used the foam roller or we would use tennis balls. Today, we have much more sophisticated equipment to be able to do self-mobilization of myofascial restrictions. Some great answers coming in. We want to increase the strength of the hip extensors, increase the mobility of the hip flexors, get that range of motion. Very good. So a little bit of insight. So we know that Jenny needs assistive movement with graded load to increase tolerance to movement. So we're in this incredibly beautiful environment in the Pilates arena where we can get her on the trapeze table, which was her favorite piece of equipment, and we can create all kinds of assisted graded load movements, the same with the reformer, to be able to give her a positive movement experience. So everybody's been sort of coming in at this in different ways of looking and saying, this is about her getting some movement, getting positive movement experiences to help her with some of the depression and the frustration that she's having, and also to prove to her that she's able to do a full workout. She can go work out for 50 minutes without having an overheating session because the Pilates is so friendly to her. Second insight, basically that loss of hip mobility. So increasing hip mobility will result in increased ability to stand, improved balance, bed mobility, and activities of daily living, as we mentioned. So we really want to get her mobilizing those hips and be able to get a little bit of strength. She has weakness in the hips, but we didn't feel that was as neurological as it was in the lower part of the lower extremity, in the calves and in the quads. So if we can get the hips and the core to work more, that would give her a lot more function and tolerance and endurance. So what principles of movement would you want to facilitate for Jenny at this stage of the game? So thinking of the movement, we have principles of breath, mobility, alignment, control, and movement integration. They're all important, but which one would you prioritize for Jenny at this very early stage of her coming back into movement, discovering movement? All right, so I see breath and mobility, and I think those definitely are probably the two biggest and most important ones. I started with breath. Some of you said it early on that if we could just get her starting to have deep breath, get a little more expansion, some diaphragm exercising, that would probably be able to give her a little more energy in her day. And then the other thing we look at is mobility, particularly we all talked about getting that hip mobility would be the other priority. So those were my two basic priorities in the beginning. And then as I was able to get the hip extension, then control became incredibly important, right? Because now she needed that core to be able to engage, to be able to help hold her up, as well as the whole pelvic region to be able to support her. Beautiful. And again, there's no wrong answer inside of this case. So in summary, we basically said that with Jenny, the structural restrictions we felt were the hip mobility and the weakness in the core, the trunk control. We felt that was really the biggest area of structural. From a strategy perception, we felt that she really needed a positive movement experience. We wanted to have her have a successful sit-to-stand experience. I felt like that gave her independence. So if you think about her sitting in her chair, she needs to get up and do something with the kids. If she can stand up and get to the walker, which is next to her, and do that independently, gives her a great sense of independence. And then overall, increasing her endurance without overheating. So hopefully all of you we all agreed on this, basically coming together on this one. So how can her Pilates practice help her now? So we sort of got this vision. What do you think would be the key objectives that you would want to see coming directly from the Pilates program? While you're answering that question, think of the more global benefits of doing Pilates as well as some of the intricacies that come to us when we practice Pilates. And this is a little more complex question, so I want you to think about it. You can answer more than once if you need to. But how can her Pilates practice make a difference for her, right? And we've talked about things that are psychological, emotional. We've talked about the physical, the strength, these positive movement experiences. What are you expecting? If you had Jenny as a client tomorrow, what would you want to set as a goal for her in her Pilates practice? This is not so much the exercises, that will come next, but what do you want to set as a goal for her based off of everything we've discussed so far? To get her keep coming, right? So that'd be a big one, is to be able to have retention with her coming in and that she's compliant. Very good. To be able to give her some strength and confidence that she could feel a little stronger. Relief from depression, restore movement proficiency, some great answers in here. Get her gait training, very good. And I think a lot of, and I know because I treated her, but a lot of her deficiencies that she presented with were disuse atrophy. They were related to the fact that she had sort of given up. She had been dealing with chronic disease already for more than 20 years. And it was frustrating. And the big challenge that came into her life now was all of a sudden trying to raise 3 young boys, the youngest 3 years old. So that was a huge ask on her personality. Now, there's another thing that is rumored. I don't know how true it is, but I've often heard that many individuals with multiple sclerosis also have like a type A personality. So they really like to get everything done. They want to be involved in everything. And I often have consulted with them and said, look, you have these 5 things. You're CEO of a company, you're a mom, you're the president of the PTA, you're involved in church service organizations, you insist on going on vacation with your family, and you plan these exuberant vacations. Like, pick 3 of those 5 things that you want to do and get rid of 2 of them. And a lot of times it's really about managing the expectation of how much energy they can expend, right? We know that the greatest symptoms of MS is fatigue and weakness. So if we can be able to control a little bit of what the expectation is and then increase the strength and function, they can have a much better quality of life without a lot of the psychological challenges that come with not being able to do what we expect of ourselves to be able to do. So if we align the expectations, can make a big difference. I see some other ones in here. Improved movement experiences. She feels she's able to get beyond her present state. And that was exactly what we did through those first couple months with Jenny. Let's see other ones in here. Changing her posture will give her confidence. That was Joseph Pilates' statement. He felt that, people who did Pilates or Contrology back then, that they would notice an improved posture, and that was associated with increased confidence in whatever you're doing in life. And I've seen other studies that are very interesting. For example, if you all slouch right now, slouch really far down, and then try to smile. And notice how the smile is very artificial and very laborsome. And then if you come up into a nice posture tall, the smile is actually very easy. And we can actually do the opposite. Sitting nice and tall, try to frown. And then go into the slouch posture and see how easy it is to frown. So there are neurological pathways associated with posture and mood. So you're right, if we can get her to be more upright, to have better posture, maybe to see herself in the mirror standing tall with better posture, could put a smile on her face just neurologically and make her feel a little happier. Good information here. Great. This is where we're looking at the exercises themselves. And what I'm more interested here is not the exercise, but the modification to the exercise that would allow you to give Jenny a positive movement experience. And this is where in Polestar we shine. We love being able to modify an exercise that otherwise would not be accessible to an individual because of their impairments, and teach them and provide some kind of modification that allows them to participate, and as somebody mentioned on the last slide, to be able to have compliance, to keep coming back and participating in their Pilates program, right? The attrition, when a lot of people come in and they want to do exercises, if the exercises are too rough or not challenging enough, you don't have retention. And the worst thing that we can do with anybody is lose that or to have high attrition. I often talk to studio owners and I ask them, what's the average stay of your clients, because I also often hear them say, "Oh, I've got a waiting list 3 months long. I can't get people in." And I said, "That's fantastic from a business perspective, but how long do your patients stay? Because if it's just you and you have a waiting list, then that means that every month or 2 months you have a turnaround that people are not continuing their Pilates. So what is your attrition in your Pilates studio?" And what I would do, and I've done it in the past, is I asked the people that stopped coming, what was the reason for discontinuing Pilates? Well, some of them obviously were financial, and that made sense that they were not in a position to continue paying for Pilates classes or private sessions. But the majority of them were their needs were not being met. So what I think of when I hear that is that either the class was not challenging enough, or that it was so challenging and they were so deconditioned, which was the more common answer, that they were not able to continue with the discouragement of always being sore. And so in this particular case, it's super important that we're providing modifications to allow for successful repetitions, to be able to have the sense of doing a lot more work over a period of time to increase the perception of this was a workout I could do. I was able to do a 45, 50-minute workout, and I had some soreness, but I wasn't knocked out for 5-6 days from overheating. So I know that I've had some clients with multiple sclerosis that have tried to go in and do things like cycling, spinning classes, or trying to do aerobics, or trying to do other things. And it's so intense that the overheating knocks them out, and it's frustrating because then I failed at another thing, and it's like, how do we continue to challenge our clients with these special needs and still give them a really positive movement experience? Let's see what you guys are saying. Let's go ahead and open it up, Melissa. So I see some that require manual support, right? And that would be us helping them, holding their arms or their legs. We can create assistance. Remember, in the Pilates environment, we can reduce the effects of gravity all the way to completely eliminating gravity. So we can provide exercises that are within a 3 or less out of 5 for a manual muscle test. Let me go back in history. Manual muscle testing came from the polio days. So when polio affected the world, and particularly us in the nation, they came up with a manual therapy grading scale to be able to say how strong somebody was that was affected by polio in that particular limb or those muscles. So if you could lift your arm up against gravity or hold it against gravity, it was a 3+. If you could resist any kind of resistance that was a load on it, it would be a 4 or a 5. And then anything lower than a 3 was considered a trace, and that would mean that you could not actively move your arm in a gravity-related situation. You would need to be assisted. And so equipment started being developed, and one of those tables was called the Guthrie-Smith table. There's important history for Pilates teachers because Joseph Pilates was only a couple blocks away from the hospital in New York that was treating polio at the same exact time that Joseph Pilates developed the trapeze table. Now, the Guthrie-Smith table also was a Germanic origin. They have what's called the Slingentisch and things like that. And if you've been to Norway later or have seen the device called the red cord, and anything that has suspension. So the idea was when you had so much weakness that you had a 3 or lower on the manual muscle testing, that you needed to change it and eliminate gravity's effect and create more assistance. So for example, I could lay on my side and I could put a chain or a strap around my wrist that's suspended to the table above me, and maybe I could move it horizontally without much effort, even though I could not lift it up against gravity. So what that says is that I have a trace muscle, I have muscle activity, I just don't have enough of it to be able to lift against gravity. So now go forward 100 years, and here we are with our Pilates equipment, particularly the trapeze table, that is a cage with springs and Velcro cuffs from all different angles that can allow us to provide graded load. How much graded? Enough, right? You've heard me say that. I know it's a frustrating answer to a lot of people, but enough is the right answer. So if Jenny is laying on her side and we want to put a long spring and maybe have it cuffed above the knee, we could start with something where the spring is strong enough to hold the weight of her leg, and we can just have her doing a side kick. So she's starting to use her hip flexors and hip extensors in the limited range that she has, unable to lift her leg up because she doesn't have the power to lift her leg up again. So again, it's a 3 or under, but with the spring assistance, now she's able to participate in activity. Let's see what you guys are putting in. So assisted squats, very good off the trapeze table. We could even just get her doing a ton of footwork with different foot positions and different things that we can assist her with to let her just have repetition. Repetition is so important to neurological impairments. I see 90-90. That's one of my favorite. Of course, we had her in 90-90. Chair footwork, standing leg pumps, seated exercises on the chair, on the reformer, modified push-up from the chair, arm strength, good, because we can adjust those springs. So she could actually be working on push-ups with gravity assistance, prone on the chair if we can accommodate her with the hip range of motion. I see more footwork, side lying on the trap table, like I said, good job. Semi-soft balls under the sits bones, creating more awareness and balance and control through the pelvis, helping her to find a neutral pelvis. A lot of the other exercises, like dead bugs with spring assist, great exercises. I also, funny enough, I use the barrel a lot with her. So laying her over the barrel and prone and standing on her feet with her hands to the side of the barrel, we could work with her using her arms a little bit and working on the extension and the trunk control to push her up into a standing posture. She still had the balance assist by having her hands on the barrel. So a lot of fun things we could do. Somebody put the OOV in there, and I saw a couple OOVs. And OOV was not out at that time when I was treating Jenny, but it certainly would have been in my repertoire now. So I love using the OOV to create that challenge of proprioception and to re-educate that deep core organization that's subconscious. I have a question that came in. It says, we used to teach quite a few clients with MS, but found the assisting compromised our backs. Any suggestions? And, this is the age-old dilemma of all physical therapists. Where we find ourselves over-assisting and that we're actually compromising our own body. I appreciate you asking that question. This is the beauty of Pilates, though. So if we're doing Pilates correctly, instead of us having to hold up a leg like we do in physical therapy and move it around with somebody that might have multiple sclerosis or another neurological impairment, now we can just suspend their legs in the air. And with very little efforts on our part, we can mobilize that hip, we can stretch, we can strengthen, we can work on coordination. And so the assistive environment that we have in Pilates resolves a lot of the challenges that we as physical therapists faced for decades in working with neurological patients. So when you see a patient with a neurological impairment that needs a min assist, now all of a sudden we can get creative. Like I take a pelvic harness and it has a couple clips on it, and I hook it to the long springs on the trapeze table and standing and doing a sit to stand. So they actually have the harnesses lifting them from the pelvis, but only a little bit. So they have to use their legs, but they're not going to fall, and I'm not going to hurt myself as the therapist. So these are all some great answers and great programming. Appreciate it. We're all looking, this is good stuff. I want to share with you, I moved to Miami about a year after working with Jenny, and I kept close tabs of her, and about 6 years into my doctoral program, Jenny did pass away. It was a very sad day, and there was nobody to continue with her therapy or her Pilates. She really felt better with the Pilates, and again, after not doing the Pilates and not having the therapy with a progressive chronic disease, remember her version of the disease was very aggressive. So the fact that she lived to be close to 48 years old in her particular case was the quality of life that she was looking for, and a very challenging one at that. But again, like I said, I have a number of clients that live very healthy, normal lives that have been diagnosed with MS, and that's the challenging part of it, is not knowing if you're going to have another relapse, if there's going to be another episode. And unfortunately for my friend Jenny, she had a very severe, very aggressive case of multiple sclerosis. She was in a wheelchair the last 4 years of her life, and also suffered from severe depression and other challenges that she had with her children that nobody should have to suffer with. So that concludes the discussion on multiple sclerosis. Wanted to be able to get through some of the theory and then also give you a case. You're right on the money. We've got a lot of good programming coming up in the next couple months, so we hope that you'll join us in future. Also wanted to make note that on the beginning, I think it's the second weekend of November, we have 2 special courses that are here on the farm. So if you are interested in getting out of your city and coming to the farm and being with Shelley and myself here in North Carolina, I'm going to be conducting a 1-day course on gait and gait analysis called Open the Gate. And the other one is going to be a rheumatology course, which will be talking more in depth about autoimmune disease. How do we work with our clients in the Pilates environment? Again, these courses are open to everybody. You do not have to be a therapist to be able to enjoy and learn this information. Remember, our vision and mission statement is to impact global well-being through the education and practice of healthy movement. And so that's what we're trying to do, is to bring that to everyone. So the course is actually November 3rd and 4th. It's the first weekend of November. So if that works for you and you want to get some of you might want to get some PMA CEUs, we also provide those. So you'd get those CEUs for coming and get your year supply in one weekend on the beautiful Southwind Farm. And that's all I have for you today. Thank you for joining us. We will be back next week. Above all things, be kind.